Now, the first step is to set up our intestinal drainer by cutting it into two equal halves, as you can see by using a pair of surgical scissors. The cut ends need to be aligned opposite each other. For this, we will use thumb tacks or thumb pins provided in the kit to fix these two cut halves on the foam side of the intestinal holder. Make sure that the cut halves of the intestine are properly secured, or else it might be difficult to carry out with the procedure. As it can be seen, the two front halves of the intestine should align and bulge out. An assistant can help to hold them in place. So coming on to the techniques of anastomosis, here we will be doing an end-to-end bowel anastomosis. An assistant will hold these two ends of the bowel loop together. In this demonstration, the mesenteric end is considered facing towards you and the anti-mesenteric end facing towards the assistant. Firstly, we will take a hold or the stay suture. Going on to the anti-mesenteric side and taking a fine suture going in from the outside into the bowel lumen and coming out of it just a bit medially on the same loop. Again, the same thing will be done on the opposite loop, coming in from the outside and leaving inside out. As you can see, we have taken these sutures a bit far from the end. Now, we will approximate these two tissues and tie it off. We will cut the long end, whereas the short end will be grasped with an artery forceps and will be given to the assistant to hold. This procedure will align your two loops together. Now, we will repeat the procedure on the mesenteric border by taking a stay suture, just to align our two loops together. Again, the maneuver will be to go outside in, followed by inside out. While carrying out this stitch, we need to make sure that we do not damage the blood vessels. We will repeat the same maneuver on the other loop. We will be going outside in and leaving inside out of the same loop. So now, as you can see, we have our four limbs, two anterior limbs and two posterior limbs, which you can see are in approximation with each other. We will start with the anastomosis from the posterior wall. We need to be very careful while working on the edges because edges are primary places where leaks happen. So we have to make sure that we are working carefully on the edges. So again, the maneuver will be to go from outside in, followed by inside out on the same loop of the bowel. Again, outside in and leaving inside out. On the other loop, the maneuver will be the same. We will be going outside in, followed by inside out. This step helps in securing the edges. As you can see, this is hardly 0.5 millimeters from the top of the edge. So now, since we are outside and we will be suturing the posterior wall, the next step is to go inside the lumen. So now you are inside the lumen. While suturing the posterior layer, we need to make sure that you are getting a good chunk of the seromuscular layer. While doing this, if the mucosa comes in between, you can pull the mucosa down with the tip of the suture needle and come out. You will repeat this procedure on the other side of the loop as well, keeping in mind to take full thickness bites of the tissue. We will end the procedure by locking the suture. We will continue suturing the posterior wall by again taking a full thickness bite of the tissue. Again, we will finish this step by locking the sutures. We are locking just the initial one or two sutures. After that, we are taking full thickness continuous sutures. And we will be locking every third or fourth suture. This intermittent locking will prevent progressive pulling up and narrowing of the lumen. We can see how the two ends are approximating to each other. We will continue suturing till we reach the end, locking every third or fourth suture. We have almost reached the end, so again we will be locking the suture. This is the posterior layer which has been repaired and in continuity with each other. It can also be seen that the backside has been opposed properly. Now, coming on to the anterior layer. Since our suture is on the inside, we will push the needle out and again we will secure the angle first by using the same technique. The maneuver will be to go inside out followed by outside in from the same side. Again inside out followed by outside in from the same side. And we will tie it with a small loop. Make sure you do not cut this loop and that you suture ahead in continuity. Now the assistant will hold the two loops together in line in front of you. Here we will just be taking continuous interlocking sutures. We need to make sure that the edges are properly inverted and not averted. We need to make sure that we are taking a big chunk of the seromuscular layer and less chunk of the mucosa. Because if we take more mucosa, then there is a chance that the mucosa will pout out and avert. Now, we will start suturing the anterior layer. The procedure would be similar to the way we sutured the posterior layer. We will be taking continuous sutures and locking every third or fourth suture. This intermittent locking helps us to make sure that the edges are secured properly. As we are suturing, we need to make sure that the edges are properly inverting and not averted. Again, every time you suture, you need to make sure that we are taking a big chunk of the seromuscular layer and less chunk of the mucosa. We need to avoid taking more mucosa while suturing because that increases the chance of the layer everting and the mucosa spouting out. So this is how the anterior layer has been approximated. As we can see, the edges are properly inverting both anteriorly and posteriorly. Now, to reinforce the suture line, we will be taking one more layer of intermittent sutures called Lembert Sutures. These sutures that we are taking are not full thickness, but rather seromuscular sutures which are taken from some distance from the primary suture line. But remember, they should be adequately thick or they will cut through and damage the suture line. So now, when we are approximating, these two ends should come together. The assistant will cut the two ends, and what we get is a primary suture line which is getting buried. We will continue taking these Lambert sutures, which are to be taken at a distance and are intermittent in nature. As we can see, if it is not a proper bite, then we will have sutures cutting through the tissue. So you need to make sure that you're getting adequate chunk of the tissue while suturing. This way, we will bury our entire primary suture line both anteriorly and posteriorly. As mentioned, we will continue taking these sutures even on the posterior layer. Again, make sure to take adequate chunk of the tissue. The assistance help over here is required and it's needed to hold the two loops together and bring the edges together. But be careful that we do not poke the assistant's hand. We can clearly see how the primary suture line is being buried by these Lembert sutures. We can see the entire previous primary suture line buried by the Lembert sutures. At the end of the procedure, we need to make sure we feel the continuity of the lumen. Also, make sure that we have not taken the posterior layer while suturing the anterior layer. Use your thumb and the index finger to palpate and feel that there is nothing coming in between the two fingers. After this, we will close the defect in the masonry. Once the bowel is anastomosed, we need to close the defect in the masonry. This is done to prevent any internal herniation of the bowel through the defect. While doing an anastomosis, we need to make sure that we are achieving proper hemostasis, but at the same time, keeping in mind that we're not compromising the vascularity of the bowel. Because if we are compromising the vascularity, the anastomotic end will necrose and leak. But if you are not maintaining hemostasis, the patient will go on bleeding inside the lumen and will end up with hypotension because of the hemorrhagic shock. Finally, we have completed the anastomosis, which is strong with a proper lumen.